And a lot of treating physicians have this really big hang up on what's the antidote? Well, the antidote is usually take good care of the patient.
Great. Okay, that makes the second question there moot, so we'll just move on. The patient was started on a naloxone infusion at 1 milligram per hour. There's the capillary gas post resuscitation. She continued to have problems with blood pressure, glucose, treated with some calcium, dopamine, atropine, some more Lasix, some bicarb, some more glucose, and some more fluids. We finally were able to insert an art line and get an art blood pressure on her. She's remained hypoglycemic, hypotensive, and acidotic. So we're now about 3 hours, 20 minutes since she was discovered, about an hour and a half since she arrived in the emergency room. The ongoing blood pressure issues were treated with increasing the dopamine infusion, D10 boluses for the glucose issues, and bicarb boluses for the acidosis, as well as ventilation. The call was made to the air medical team to transfer the child to the nearest pediatric intensive care unit. So it was at 2:40 in the afternoon that the Poison Center was finally called about this case. So there was no input from the Poison Center up until this point. So what was described to the Poison Center was it was a methadone exposure. Patient was intubated on a dopamine drip, and they wanted some basic information on methadone. So we're just looking at methadone, synthetic opioid receptor agonist, used to treat chronic pain or a maintenance substitute for opioid dependence. So with an acute methadone overdose, when would you expect to see the onset of symptoms?
I'm aware that the methadone that his child would have gotten would have probably been in a liquid formulation. There are tablets as well, and so the onset of symptoms would have been different depending on whether it was a tablet formulation.
It was a liquid formulation.
So a liquid formulation, a naive child not used to getting methadone probably would have had symptoms onset fairly quickly after an exposure. Sometimes 15-20 minutes can be the earliest onset of symptomatology. The time to metabolism, so that you actually had metabolites measured in a urine sample, would have been longer. I can't tell you enough about, would have been an hour before you start to measure them, or 4 hours? Somebody else who's a PharmD might know better. As far as the onset of the metabolites, or to detection of the metabolites.
As far, actually, I don't know exactly how long until you can detect the metabolites in the urine. But I mean, as far as the onset with the liquid, I mean, I agree with you. As far as usually, you normally see that within 15-20 minutes.
The half-life is like 24 hours.
And how long would you expect symptoms to last with this?
Can be days.
I was just commenting in the back here. I'm trying to hide. The half-life, it's about 24 hours, so you're going to have a long period. That's why it's used. That's why methadone, was originally used for methadone maintenance clinics for opiate addiction, and then it's now moved over to chronic pain patients who are on opioids because of the long half-life, and it kind of smooths people out. So that's the problem with the drug. So you'd expect symptoms for a minimum of, probably around 24 hours, if not longer, depending on the metabolism.
Okay, thank you. Okay, so the child was flown from her home hospital to the PICU. During the life flight team's care, a Lasix infusion was started, bicarb infusion, antibiotics were given to cover for aspiration. The naloxone infusion was discontinued, and epinephrine infusion was started as well. She arrived in PICU about 8:30 at night, and that was what was infusing at the time. When the C-SPY contacted the PICU resident, this is what they were told. So around 10:20 that night, about 12 hours post-discovery, the resident called the poison center to ask what dose. They want to restart the naloxone infusion. They don't think it's going to help, but they want to start it anyway. So wondering what dose we should start back on. And I think I know your answer to that already, so I'm just going to keep going. See, I learn.
No dose.
So the C-SPY consulted with the on-call medical consultants, and the dose recommended was 0.1 milligram per hour. So at this point at night, about 11 o'clock at night, about 13 hours later, we find out a little bit more history. Dad's methadone was mixed in Tang in a cup in the fridge. His dose is 120 milligrams, and they felt the child could have ingested 30 to 40 milligrams, and probably between 6 and 9 p.m. the night before.
So there's a 24.
So we're about 24 hours now. So just a little bit more about the case. Day 2, they get the electrolytes, acidosis corrected. She remained ventilated and on some infusions. Deteriorated in day 3, mannitol given, pupils fixed and dilated, and they started talking about organ donation at this time. But they were certainly concerned about the hypoxic insult to the organs. So we got a call on day 4, again from the PICU, wanting to know when can you turn off the naloxone infusion. The only methadone testing we can get in the province is qualitative, and the urine sample is still positive for methadone. So, should the naloxone infusion be discontinued if your urine drug screen is still positive?
You cannot use drug screens to determine therapy. They are just the presence or absence of a metabolite. They're meaningless for that purpose.
I think that's an excellent point. We ought to just, in general, presence of a drug in the urine does not mean clinical effect, whether this case or any other case. And too often, we'll have a patient, we'll get a urine drug screen and say, oh, it's positive for benzos. So obviously, the effects are due to benzos. Maybe, maybe not. So it's an indication of past use, but it's not indication of current clinical effect. So, with the urine, and that's, I think, very, very important thing to remember with the urine drug screens.
And I also think you have to remember that, of course, this case, we had a good history of ingestion, but the fact that you have a positive drug screen for one substance does not exclude the possibility of other substances that are not picked up on the drug screens, and many other substances are not picked up on the drug screens.
In this particular case as well, we don't think the naloxone infusion is contributing at all to her care. Mm-hmm. It's the aggressive supportive care that she's receiving, the inotropes, the pressors, the intubation, ventilation. It's of no benefit in this case anyway, so it could have been stopped before it was started.
Okay. And then that leads into, can you declare brain death if you still have a positive methadone level in the serum and or urine? These are the questions that were posed to us.
I think that if you have other objective criteria, like a blood flow study or something like that, that is consistent with brain death, I think it's irrelevant what's in the, if you have a metabolite.
Okay.
We find many metabolites present at autopsy.
Okay. Any other comments? Okay. It was recommended to continue with the naloxone as it felt it was doing no harm. It was on day 4. She had an MRI showed some herniation, tonsillar herniation, and a diffuse swelling. Deteriorated on day 5, further descent of the tonsils, diffuse edema. She did go to the OR for a post-fossa decompression. Day 6, a nuclear flow scan of the brain was performed, which did demonstrate conclusive absence of cerebral blood flow. So she was declared dead at 7:30 p.m. that evening. And the parents were given permission from Child Services and the medical examiner to make decisions about organ donation. We didn't have these specimens back because they had to go out of province before the patient's death, but that does show there still was a small amount of methadone in the serum as well as in the urine. So are there any dangers involved in using organs from a methadone overdose? And have you had any experience with organ transplants from overdose patients?
I'll take a stab to start. There are, except for the hypoperfusion and hypotension, et cetera, there would be no dangers from using organs from a child like this, from a methadone overdose in particular. It might depend on other drugs on what the organ was that you wish to transplant. Ethylene glycol, poisoning, death, and taking the kidney, for example, would not be beneficial to the donee. So yes, we have recommended that you can take the organs from patients who've died from overdoses, depending on the organ that it is that you want, that you need to use, and that there's no other risks because of lack of perfusion, because of HIV and other infectious diseases, depending on the donor characteristics.
I would agree. You really don't have any reason. Remember, just because it's positive, it may just be a very, very small amount anyway, and there's no downside to the methadone in the organ.
Anybody else? Okay, in the end, the heart and kidneys were harvested for organ donation and were successfully transplanted into their recipients. And as of last month, they had not heard of any organ rejection, so they were successful transplants. Okay, so this was quite a tragic case that should have been a preventable poisoning. Lots of questions have been raised